And from sports, we get into our big stories. We start from the end of the COVID-19 pandemic. It's about ending all the talk over compulsory vaccinations and vaccine hesitancy. Joining the conversation, our guest, Dr. Kwame Sapong-Esiedu, CDD Research Fellow. We also have Dr. Fred Adomako-Boateng, Bono East Director of Health. We'll try to get a representative from maybe the health services to find out what they can also say in respect of this, the Ghana Medical Association as well. I'll start with you, Dr. Kwame Sapong-Esiedu, and it's good to have you. I love your staircase, by the way.
Thank you, and thanks for having me. And good morning to your listeners as well.
Okay, so to kickstart the conversation, we've spoken about a fourth wave that we are supposedly riding. Looking at the recent figures that we have seen, Dr. Sapong-Esiedu, we've seen a downward, a spiral, if you like, of the COVID-19 numbers. Do you think this is indication or indicative of the fact that we are out of the woods, we are getting out of this fourth wave? Has it come to an end?
Well, thanks. Two things are happening. The first is that this is the highest wave we've had by far since COVID-19 came to Ghana.
Right.
That's the first thing. And so you would see that, like with any wave, you don't know you're past the wave until you're past it. It's very difficult to predict you at your peak because you go past it and there has to be what we call a 7-day trend in decline, which we see haven't. I would say we're gone past the peak on that basis and that we are on the climb. But that's just one thing. The second thing is how COVID-19 behaved, called the day 10 indicator. Because when you get to day 10, one of two things will happen. Most people will get well and be out of the woods. For others, that's when the decline starts. So they'll start getting more seriously ill. Then there could be hospitalization. Then there could be severe disease. There could be critical disease. And unfortunately, there could be mortalities. So we are in that second phase where, though we are on a decline, we are not out of the woods yet because whatever we did at Christmas, we cannot stop. And that was the position I was making. Those cases would have to travel through the trajectory of what we call the COVID cycle. Right. So for the 75% who are mildly symptomatic to ride the wave and become non-infectious, for the remaining the wave of a proportion critically ill, a proportion being hospitalized, a proportion unfortunately passing away. That is the wave we need to observe properly. And if anyone has observed, January we had close to 90 deaths, which was indicative of that. December, we had close to 90 deaths, which was indicative of that. In January, the deaths have continued, though people are not actually looking at the data as much as journalists looked at it in the past. That tells you that this phase is not over.
Well, the phase is not over. Dr. Adomako-Boateng, I don't know what your take is on that. Do we find ourselves in a good place currently when it comes to COVID-19 and combating it? In other words, have we successfully ridden this wave?
I think I agree with Kwame. It's still early days yet. And it's our behavior that will really tell us whether we are going to be out. You know, you can have a lot of waves within the bigger waves. So that is one in terms of transmission. Then secondly, you know, as he said, we still have some patients who had severe and critical disease in the hospital. So though maybe the rate at which we are going to get new cases is going to decline, we should remind ourselves that we still have these severe and critical cases in the hospitals, and that is the challenge for COVID. And it's likely that maybe the morbidity is still not over yet. But we cannot say we are still out. We have to give ourselves some time before we can really come to that conclusion.
Where would you say we find ourselves, the actual figures when it comes to vaccination, the numbers and all of that. I don't know whether from where you sit you have the national picture, because different numbers have been bandied about, and some people are becoming concerned about whether the numbers we are touting are actually what we have. How much do you know about that you can share with us?
If you come to Blue East, I can speak to the data that we have in Blue East. You know, the eligible population that are due for vaccines is 730,700.
Right.
This population, we need to be vaccinated. And out of this number, 352,133 has gotten at least one dose. At least one dose. And out of this, about 90,000 have gotten at least 2 doses. So it means that if you are talking about those who are fully vaccinated in Bono East, we are about 12%. And those of us who have gotten at least one dose, we are about 35% in Bono East. So that is where we stand in terms of vaccination status for Bono East.
Right. So an interesting picture you paint there. Do you feel we've got to the point, since the waves keep coming, and we've seen these waves not just in Ghana, but in other parts of the world? In fact, in the West, we have European countries still struggling. The UK is still in the midst of that final wave of COVID-19, or the latest wave, I should say. We've had Israel, which still has one of the largest chunks of its population vaccinated, grappling with the same, to the point where in recent times we've had to even ban travelers from there. But do you feel we've got to the point, on the back of all of these developments, of having booster shots being made available? Even, I know we've not captured the entire population when it comes to first or second vaccinations, but do you feel we've got to the point where even those who got vaccinated very early should be getting booster shots? What's your quick take on that, Doc?
So basically, what we still have to look at the data for. I mean, that's what we can use to make definite points in these discussions. And normally, I think when you are talking about booster, you are looking at a lot of parameters. You are looking at who are getting the disease,
right?
What is the severity in those who are getting the disease, and other indicators will help you to. But you know that where we are now, even we are struggling with people get 1, 2. So the booster will come, but as it is. I think extensive work has been done, and we can look at what is happening in the other countries. You know that now a lot of health workers are getting sick,
right?
And though we had our vaccines, I mean, if you look at in terms of the segments of the population,
right,
those who are among the vaccinated, health workers are among, and so you still have some breakthrough infections among health workers with COVID-19. Therefore, I think if you are thinking of who to give the booster, I mean, it's clear. If you come to Bune's, for the current wave that we are having, we had 4 deaths. And out of these 4 deaths, none of them had even 1 dose.
Okay, so as far as the Bono East region, your region is concerned, those who are getting severe cases, those who are passing on, are those who have had no vaccinations. But here's the other side. Here's the other side to the story. Across the world, we've also had, and here we don't have the statistics yet, but we've had people who have had both shots who are still succumbing to the disease. In fact, some are saying that they are the ones who are driving the disease, because they may not have the severe effects, but they can get it, they pass it on, and then other people also have severe effects, which is why I was talking about a booster. Not because I don't appreciate the fact that most people have not even got the first jab or the second jab, but the fact that people who have even got the 2 are still succumbing to some of the latest mutations of the virus, and whether we should be considering, in a more holistic manner, getting boosters even ahead of fully vaccinating people with the second shot.
Yeah, I think the Ghana Health Service leadership and the Ministry of Health, they are looking at the data and then they will come to that point. But what I would say is that even if you look at us who have gotten the 2 doses and still having breakthrough infection in Bono East,
right,
I can say that none of the health workers have come down with a severe or critical form of the disease.
right.
As for Bono East, we are collating data as to who is being infected, health worker across. We can confidently say that none of the health workers have come down with severe or critical disease.
Okay.
Nevertheless, we still have the infection, and you see the disability that comes with the infection.
Right.
Therefore, we can make a point, and you know that we will also have to take care of other people who are maybe the pregnant women, the children. So we have a point in making that at least we should get the boost. But I think the leadership of the service and the Ministry of Health are thinking about as to the way forward in terms of the booster. But
Okay.
I think the data for us, we have that. I mean, there's the need for health workers to get booster. Not only that, the security officers and others, because of the nature of work that they do. Right. And mind you, if a health worker gets the infection, looking at the isolation days, if you have about, let's say, 30% or 40% of your workforce sick, and they are supposed to take some days off, you know what will happen, the long-term implications. So these are all the other things that you have to take into consideration in making a point for either people who have to get booster and others. Then the other measures that should also be taken into
do hold right there for me, Dr. Sapoyesiadu. So I'd like to find out from you what your quick take is on this bit about boosters. In Europe, for example, the European Union has been talking about the fact that, yes, some people have already got booster shots. Others are in the process of thinking of getting second booster shots, which would mean that they've taken 4 doses, 2 original doses, then a booster shot, and some are thinking of having further booster shots. But on the other side, while they say this is good, some have also suggested that we can't keep getting the booster shots. They are saying it would weaken our overall immunity. While there are others who are also saying that looking at how the virus is constantly mutating, we may be on a path of perpetual booster shots, shot after shot after shot, depending on how the person reacts, depending on time and all of that. How do you appreciate all of this in the Ghanaian context?
Thank you. I want to look at this from a number of points. The first thing you've talked about is the booster shot. The first question I ask is, why do we vaccinate in the first place? And we vaccinate for a number of reasons. Key amongst them is to stop mortality. That's the main thing. You don't want people to die. Then the next thing is to stop hospitalization, because if you can block hospitalization, then you don't go through severe disease, critical disease, and death. And if you can do that, then the next thing is to stop infection, and finally to stop transmission. Vaccines cannot do all these things at the same level of efficacy. So if you look at what Fred was saying, you'd realize that the global data is clear. Amongst doubly vaccinated people, risk of mortality is decreased by 97 to 98%.
Right.
Risk of hospitalization is decreased by 95%. Risk of infection is decreased by 67%. And that is where the bone of contention is coming from. I'll go to the boosters. The bone of contention is coming from many, and part of what you asked, Fred, was that those who've had 2 doses are the ones who are driving the infection. It's coming from the fact that why are people who are doubly vaccinated getting infected? The truth of the matter is that globally, if you look at all vaccines, and I'll make analogies here, one of the vaccines that has been widely used is the flu vaccine worldwide.
Right.
After the Spanish flu. Mm-hmm. The ability of that vaccine to prevent transmission is 40 to 45% in some years. But it has been in use, and we know how much it has benefited humankind from preventing mortality. Mm-hmm. So no one in the southern or western hemisphere gets a flu jab thinking, I am not going to get flu. They get it knowing that if you get flu, you would get it mildly, and your chances of hospitalization and therefore overrunning the health system is reduced, because a part of the whole thing is what Fred was talking about. You are preventing your health system from being overrun in two ways, with cases and from the health professional getting ill. That is why the flu vaccine is being used. So if the COVID vaccine has a comparative efficacy against prevention of infection as the flu vaccine, the question I ask myself is, on what basis are we even having the argument that the COVID vaccine should not be in use? Because in actual fact, it has a higher percentage compared with the flu vaccine. That is one thing. Then that brings me to the booster shot. You have a flu vaccine annually. And there are some people who are 80 years who've had a flu vaccine every single year. And that is what has kept them alive, because they've got chronic diseases. People have multiple bypasses. Why? Because you're dealing with a virus, and viruses mutate. So if you look at the flu vaccine, you may have trivalent, which is 3 strains in one vaccine, or quadrivalent, which is 4 strains in one vaccine. That brings me to the COVID vaccine. We are getting mutants. The advantage we've had is that the mutation of this virus has gone through a trajectory where the dominant mutant strain tends to technically wipe out all the other strains, which doesn't normally happen with the flu vaccines. And that's why you have 3 or 4 strains in there. But with the COVID vaccine, when that happens, what it means is that with like the Omicron, you have what we call immune escape, which then means that the previous vaccines that were developed using the previous known strains are not as effective, and therefore you have a booster. But when newer vaccines come on board, which are gleaned based on the strain of concern, which is the Omicron, you realize that the efficacy against preventing transmission and all that is also going to go up. That is why with the flu vaccine, you realize that the strains change every 6 months, because they look at the predominant strain in the southern hemisphere to develop the northern hemisphere vaccine, and then 6 months later do the same for the other hemisphere. So to answer your question, based on that pharmacology of the virus and the development of vaccines, I see nothing wrong with us having perpetual booster shots, because it's actually been going on. And let me tell you, it's not even just with the flu vaccine. If you look at things like tetanus and other vaccines, they'll tell you after 10 years, you've got to have a booster. Who's complaining? It just depends on the microorganism you're dealing with. Unfortunately, viruses mutate quicker than other microorganisms.
Let me ask you very quickly, Doc. So basically what you're saying, just to confirm, make clear, is the fact that we could have a situation where year on year, for some people it could even be 6 months, 8 months, we have to keep on taking the jabs as this virus, COVID-19, keeps mutating. But mind you, the other aspect of what I said was that some scientists also say this could weaken our immune system overall. And I'll be citing something I just got from the UK Health Security Agency. But so those 2 bits, are you saying that we could get to the point where year on year we have to take this? And what could be the implications for our immunity generally against even other diseases?
And that's why I make parallels here. You realize that with the flu vaccine, at the height of the Spanish flu, there was global vaccination when the flu vaccine was developed. Now, by and large, you don't have flu vaccinations in places like Africa. And when you even go into Europe, it's the at-risk population. I see a situation where when vaccine coverage globally increases and more people have had 2 jabs and plus a booster, the likelihood of wanting to have repeated boosters in the not at-risk population decreases, similar to the flu vaccinations, and just protecting the at-risk population. Why? Because their immune system doesn't have the capability of maintaining even what we call the T4 and B4 recognition systems, which allows the body to identify the virus once you've had it before. And that is why, if you listen to some people in the WHO and others, they are saying that one of the problems we are having with the mutations is because there's low vaccine coverages in parts of places like Africa. That is what we should concentrate on if we want to break that cycle and the risk to our immune system. At the moment, we cannot have the immune system conversation when we have disproportionate vaccine coverage. Just as Fred said, even in the Bono East region, you can see that there are fully vaccinated numbers are very, very low. And that is what we should focus on. If we drive those up, then those risks will go away. Until we do that, I'm sorry, we are not out of the woods yet.
Right. I'll get the specific information I'm looking for from this report I was citing. It actually is the UK's Health Security Agency, the Week 42 report on COVID-19 vaccine surveillance. And I'll just pick something. I'm looking for that specific piece. But let me come to Dr. Fred Adomako Boateng. So your reaction, maybe, I'm sure you might have some reaction to what I've been putting to Dr. Sapong Asiedu. And what is the way forward for your region now that, of course, there's a shortfall? When are you looking to attain your targets in terms of vaccination levels? Are you looking at what? How many months are you looking at to achieve those targets?
So we've put in some mechanisms. In fact, Monday, we had a virtual meeting with all the medical directors and all the district directors. And one of the main strategy that we are going to use is to increase the number of teams. That is one. And the second low-hanging fruit that we saw that we are not using is that at least we should have started vaccination sites at all the facilities, so hospitals, health centers, where we have a lot of maybe caregivers coming and other members, population coming, that if they are not vaccinated, they will be have the opportunity to be vaccinated. These are the two key main strategies that we are thinking that we'll be able to capture a lot of them. And then also to have stations at the marketplaces, lorry stations, to be able to give to people those who are not. We believe that the problem is really the access to the vaccines, because a lot of people wake up early in the morning to go to their workplaces, to go to the market farm. So if we don't have strategies to get them, it will seem that people really do not want the vaccine. That's not actually the case, because they don't have the access. So these are the main strategies that we are going to do. The other thing that we also saw, together with what we are doing, is that still the enforcement is a challenge. We are not saying that the vaccines do not kill the virus. So you should have a way that you also prevent people from also getting it. And that's what we will also state, that the try and tested methods, adherence to the COVID protocols are still key in breaking the transmission. If you notice, I mean, in all countries that have even the coverage very high, if you lose guard in terms of adhering to some of the protocols, then it means that you are going to create the environment for the ability to spread the virus. And I have to state that, look, we are in early days yet. Remember with the yellow fever, every 10 years, I think you were supposed to get one. But now the policy is that once you have gotten one, it's okay. So these are the things that we should look at when we are discussing these issues. More importantly, the morbidity issues. You have a lot of people getting sick and not coming to the facility. What do you do for that? The sheer numbers, and I think Kwame has alluded to some of these things. So we still have to discuss. And I think one critical thing that we should look at is our data, national data, regional data, even district data, and then so that you can put some of these in context and discuss as to what we are having over here. So these are some of the things that we will do. Thank you.
I just want to avert your mind, and I'm sure you followed that development where some of your colleagues, the concerned doctors of Ghana, have said that this entire vaccination drive is not based on reality. Pharmaceutical companies, big ones across the world, multinationals are milking the system. And what do we have to show? It is the protocols that are keeping us, basically washing our hands, not touching our face, wearing masks, though some people have specific problems with that. And the pot of protocols we've been following, not necessarily vaccinations. Those are not going to serve our purpose, especially as we have to expend so much to get these vaccines. The Ghana Medical Association has responded to that, but don't you feel the doctors also make a crucial point in what they are saying? We can't keep up like this, can we?
Oh, if you reach, I think once it's a group of doctors that have come out, we just have to refer to their body, the GMA, what the GMA has stated. But some of the allegations, I think the big pharma, the tactics, I wouldn't want to go in there. I'm a scientist, and then I need figures and what the figures are saying. And globally, I mean, medicine is informed by evidence in terms of trials, random clinical trials. So
they base just so you don't paint the picture that they are not providing any evidence, so to speak. At least they have their own categorization of evidence. They say what we see, the trajectory in other countries. Why, for example, have we banned travel from Israel? Okay, Israel has one of the best vaccination rates across the world, but they are currently grappling with another wave of COVID-19. They are struggling with it to the point where Ghana has banned, travel from Israel to this country. They are talking about the fact, and I just have to repeat this, that in the American state of Vermont, of course, maybe they cite one, there could be others. When you look at those who are getting infected and passing on in recent times, 79% or so of them are actually those who are taken 2 doses. This is not to create a negative picture of the vaccines, but we need a holistic conversation on it to know what they are saying. Is it real? Is it just a segregated group? Can we take that minuscule information they are giving and spread it across the board? Those are the questions.
When it comes to causality, it's not an easy task to really talk about association. The mode of which you make that convincing conclusion should go through some rigorous scientific research.
Right.
I mean, this is an allegation. Until you put in mechanisms really to test this association and causality, it will be difficult for us to go. It's an observation that maybe they are saying and they are making. So that is what I will say, that assigning association and causality, we have a tried and tested ways of going there. There are a lot of parameters that you will have to look at. There are a lot of cohorting that you have to do, at a lot of stratification that you have to look at. I think we have to wait for that to be done before maybe we start making. And for all that, maybe the way that you go about even arriving at that conclusion in one work will be different from others. So I think based on what we have, I can really talk to the figures that I have now. In fact, the figures that I have even given to you and we have looked at mild diseases in people who are vaccinated and those who are not. We term it a relative risk, and it's a crude way of analyzing that because we have not been able to stratify in terms of age, sex, and all those. Right. So on that basis, I mean, I cannot stand and then based on those observations make a convincing conclusion. And that's what I will say, that look, science is evolving. We know the tried and tested methods that we know, but that our behavior has been driving the infections more than others. So these are all things that we have to look and address it holistically. Right. And that is the point I will make, that look, for what we are seeing in terms of severe disease, critical disease, people coming for admissions, the vaccines have reduced that for us in Greece. At least we have the figures that we can attest to. That one I can be firm to state that. So that is what I will add in that section.
Okay. Let me come to you, Kwame. On that same beat, there appears to be this suggestion, before I go to the bit about medication, there appears to be this suggestion from that report I was citing a short while ago. in terms of week 42 of the COVID-19 vaccine surveillance, which seems to suggest that maybe those who have been doubly vaccinated may lose some of their natural immunity, okay? And I was trying to get the specific page to read out for you. But what would that be indicative of when it comes to COVID-19 if over time several uses of the vaccine provide some weaknesses in our immune system? What could that mean if this over time proves true? What could that mean?
Well, I have the week 42 report, and I actually have week 1 of 2022. I did share it with your producer yesterday because I was going to refer to those reports. What week 42 says is that when you've had a second dose, over time, your protection wanes. That is where the booster conversation started from. There's a difference between a waning protection because your antibody titers are dropping and a decline in your immune response.
What's the difference?
So the difference is that when you are vaccinated, two things happen. You have your antibody levels build, and that's why they say 14 days post your second dose is when you are very protected because your antibody levels are high. As time goes, your antibody levels start dropping. And when the antibody levels start dropping, the antibodies are your arsenal. So when the virus is invading, you've got less ammunition to fight back. And therefore, the school of thought was you give a booster to raise the antibodies. When the boosters were given, another thing happened. Apart from getting higher titers of the antibodies, the T4 and B4, which is another form of immunity conferment levels, and training went much, much higher. And that is why people are saying that after the third dose or the booster, the science is not indicating that there should be a fourth dose. The immune system issue in the week 42 report has got to do with people who are immunocompromised. If you say someone is immunocompromised, if you say someone is immunocompromised, it means that they're either suffering from a disease that is impairing their immune system's natural ability to produce antibodies when they are vaccinated. For example, they've got a cancer, they've got an autoimmune disease, or they've had, an organ transmission, so they are being given immunosuppressants. In people like that, the immune system gets what we call lethargic when you try to probe it and probe it and probe it. Those are distinctions that those reports are making. And so we need to read these reports dispassionately. Now I come to the question you were asking, Fred, around why we have banned travel from Israel. The issue about banning travel, because I've got the Israeli report from Clilit, and I've got, like I said, I've got the UK Security Agency report. I was looking at both yesterday. The reason why we've banned travel from Israel is due to the high transmission rate that's going on, their positivity ratio. And not because they are getting hospitalizations and mortalities, because if the person can get infected, they can transmit. So for a country like Ghana, where the Ghana Health Service probably has limited bed spaces, you want to decrease the risk of people testing positive at your airport and therefore becoming a problem for the health system. That is why there's the antigen testing at the airport, for example. But they started realizing that the number of people testing positive was going high. And if you look, the Ghana Health Service had to change their policy so that for people who could, isolate at home, they could isolate at home. Right. So what you do is you put in other restrictions from how I see it. And that is why they put it. Because if you look at the Israeli data, mortality is flattened. Severe disease is flattened. The same is happening in the UK. I'll give you examples. When we're having 40,000 cases in the UK, we're having close to 1,900 deaths every single day. Now we are having close to 200,000, and you get 189 deaths, at most 300 deaths. That is a drop in 97% in the mortality rate if you do the correlations.
So basically, these doctors making this call, petitioning the president, they don't know what they're about. Is that what you're suggesting?
No.
Or the figures don't back, or to put it mildly, the figures don't back what they're saying.
Yes, the figures don't back what they're saying. Two, I have significant issues with the petition because the Public Health Act has been law in this country since 2012. In that, from clause 20 to 26 talks about vaccine mandates. I am wondering whether you petition the executive without parliament to set aside our laws, or you are petitioning the president not to implement our laws because they are clear. If we want the law to be amended, let's go through the amendment process. Don't let us petition the president. I don't even think, I'm not a lawyer, but I doubt the vehicle you're using in our democratic dispensation is the right vehicle. That for me is another issue.
So they may not even be employing the right mechanisms in terms of getting what they want. Right.
Exactly. And then finally, they are talking about a state in the US where vaccination levels are, where vaccination levels are very high. If you have a population of 100 and 70 are vaccinated, but the herd immunity threshold is, say, 89, because there can be transmission, by and large, the people who get infected will be in the vaccinated population. That doesn't mean vaccines are not working. These are biomedical statistics that we actually look into every single day as part of my day job. So when I see things like this, I really, really struggle. I wish I could deal with this on merit. I don't think we have the time. But I'm really struggling with this petition on a number of key biomedical science points.
So in essence, Kwame, for the sake of time, you subscribe to what the GMA has said. Let's keep on. You subscribe to what Kwame Meno, the health minister, has said. This is non-negotiable. You must get vaccinated. We have a vaccine mandate. Get vaccinated. That's it. I mean, you subscribe to that.
Yes, and I'll tell you why quickly. So far, 9.3 billion of these vaccines have been administered, which gives a vaccine per capita, if you look at the global population of 7.9 billion, of 1.2, with adverse drug reactions less than 4 in 1 million.
Right.
Anyone give me one drug that has this safety profile, and I'll have a decent conversation with them.
Right. Let's talk moving forward about how to resolve this situation, maybe from a more holistic standpoint in terms of cures. And I put cure in quotation marks. Novartis has come out in recent times, and this is still going through some trials, but you know that Merck and Pfizer have pills that can be taken with some, I don't know whether to call them palliative effects when it comes to COVID-19. Novartis has come out with its own, which the only complication is that it is intravenous, which means you have to take it. It's a drip rather than a tablet or something. But these are all developments across the world that are attempts. It's called Ensovibep, okay? So if you've, and this is to both of you, both Dr. Kwame Sapong-Essiedu and Dr. Fred Adomako Boateng. Then there also is the issue, and this is a bit controversial, but I'll get to it. The issue to do with cannabis. Okay, there are studies on that. I just want to get your honest take, where people are suggesting that the compounds, cannabis compounds, prevent the virus that causes COVID-19 from penetrating healthy cells. It talks about the mutation, the spikes, and how it inhibits their formation and all of that. What is your take on this? I know you will go to the science and tell me this and that and proof and all of that, but from what you've seen and the fact that some people are saying that the tests with cannabis, for example, have yielded very positive results, what would be your take on this? Should we be open to such adventures moving forward?
Well, thanks. My position on cannabis has always been known, and I'll reiterate it. Cannabis has medicinal uses. As a pharmacist, I dispense cannabinol to people with multiple sclerosis every day on the NHS when I'm in the UK. It also has other implications when it comes to epilepsy and all that. There are licensed drugs like Sativex, which come from cannabis.
Yeah.
The scientific evidence on cannabis is evolving in other facets of controlling pain and other associated diseases. However, when it comes to COVID, I would see this as what we call a phase 1 trial. Like Fred was saying earlier, these have to go through a number of stages. The data currently, as it stands, may look impressive. It hasn't gone through peer review, so I would hasten slowly to say that is the route to go. But I'm open to the research on the basis of the journey that cannabis has come from a totally banned drug to the point whereby there are licensed medicines today that are used in regular healthcare. That's one thing. The second thing about the antivirals are not new. People have heard about Tamiflu, which is used in flu. There are a lot of antivirals that are used in HIV that has converted HIV now, if you detect it early and take your medication, from a life death sentence to more or less a chronic disease. So I am not surprised that newer medications are coming for this virus too. What's important with all the three medicines you mentioned is the fact that the intervention has to be early. For example, in the UK, now the regulation is that for people who get moderately ill, some of these medicines can actually be sent to them at home so that they start taking it earlier. What does that do? It just prevents the viral load from going high so the immune system can respond. The trigger for COVID and all the drama we see in hospital is because the immune system goes into hyperactivity. If you can decrease the viral load so that the immune system doesn't go into that hyperactivity, you decrease the risk of mortality. And that is all these drugs are doing. So whichever one you talk of, they might act differently, but the end game, as far as what we call prognosis is concerned, is to prevent the viral load from going high and therefore for people from getting very sick and getting into hospital. So for me, all those are important things. But if you get vaccinated, then you prevent that anyway. I look at the price of these drugs and I ask myself, what's the cost of a vaccine compared to the cost of these drugs? And can the Ghana Health Service even afford it? Our health expenditure per capita is only $89. Some of those drugs cost almost $1,000. Are we doing good medical economics here? And that's why I said I want to have an honest conversation based on all the information if they had time. But this is where I'll leave it.
Let's come to you, Fred.
So I think cannabis, let's continue the research and look at the effective dose if they can really have, address the issue. Then, you know, when we talk about vaccines, prevention and treatment, they have their place. And as we said, you cannot, as compared to, let's say, malaria, you have malaria and you take a medicine. It actually kills the parasite, the plasmodium. But as Kwame said, when you get COVID, there is no drug that can really kill the virus. What actually the drug will do is to prevent you from getting the severe or critical, or like he said, the virus replicating more. And the cost involved in that, compared to just having a vaccine, it will prevent you from even getting to the state where you need the drug. Which one would you go for in terms of cost? Right. So that is the dynamics when we talk about the role of vaccines in terms of managing these viral diseases. It's difficult to treat the viral diseases. The best way that you have to do is to prevent it. And what actually happens is that by the time you even get to that stage, the complications, the morbidity, other issues, the effect on the health system. Please, when somebody gets one severe or critical case of COVID, management are even equated to about 2,000 mild cases. It's difficult to manage that person. So in terms of vaccines and drugs, they have their own places that if cannabis will help us to address the issue, let's research into that. The problem is getting the right dosage so that the other side effects are curtailed. That is what we should look at.
Well, maybe we should get in touch with the Oregon State University, which actually conducted this study. But gentlemen, Kwame, Fred, thank you so much for connecting with us this morning and sharing your thoughts.
Thank you.
Thank you.
Right. And our guests on that beat, Dr. Kwame Sapong-Asiedu, CDD Research Fellow, and Dr. Fred Adomako-Boateng, Bono East Director of Health. If you had any questions, hopefully we've helped you come to some understanding of some of the issues. Up next, our next big story has to do with 21st century STEM education and what government should be prioritizing when it comes to education in the year 2022. Our guests join us next for that conversation. Do stay.